All right. So this presentation, actually, I have about 10 cases that I put together for a conference that I'm going to be giving tomorrow at my university. I forgot to mention, I'm a resident at the University of Michigan in the interventional radiology program. And Artie is a mentor of mine, so she pulled me into this situation here. So I'm going to talk about the role of cross-sectional imaging in 2 image-guided interventions. Let's see if So these are the people that helped me put this together. I don't have any disclosures, so we'll start with the first case. So this is a 42-year-old female. She had stage 4 neuroendocrine tumor with peritoneal and omental metastases and a recurrent small bowel obstruction, and she presented for worsening abdominal pain and back pain. And then interventional radiology was consulted for a possible venting gastrostomy tube. So this is the CT scan. I'm just going to scroll through it slowly. It's a little reminiscent of the case we just looked at, but there's some findings to show here, which include this big mass that we see here in the right lower abdomen ileocecal region, and that was biopsy proven carcinoid tumor. And we see lots of small bowel loops that are enlarged and dilated with wall thickening. There's some mild ascites, which we see, and then we also have some omental caking. Closer here to the top. So here, about a little more than a year later, the patient came back to the emergency room and got another CT scan. So this is what it looks like today, or not today, but at this second stage. So as you can see, she now has a multifocal closed loop obstruction with several transition points. The mass is still present here in the right lower abdomen. And we have some mural edema and carcinomatosis. So this is a malignant small bowel obstruction. And then this coronal image demonstrates the multifocal points of obstruction and the dilated loops of bowel. So our diagnosis was a small bowel obstruction with peritoneal and omental metastases from a neuroendocrine tumor with a need for a long-term venting gastrostomy tube. So normally when we think of gastrostomy tubes, carcinomatosis is thought of as a contraindication. In this case, we see a clear window for placing the tube, and so the procedure was attempted. So this is after the gastrostomy tube. This is the final fluoroscopic image. After the tube was placed, we see the retention balloon, presumably against the stomach wall, and we see contrast outlining the rugal folds. I just want to make one point that although this is presumed to be in the stomach, without a lateral image, you can't definitively determine where the gastrostomy tube is located. On follow-up, the patient had decreased abdominal pain and she was able to eat and drink, so this was considered successful. And just to make a point, here's an algorithm for symptomatic malignant bowel obstruction management, and I know it looks scary, but I'm just going to kind of break it down. So this is the path that our patient took. She came in with a symptomatic malignant bowel obstruction and then was evaluated by a multidisciplinary team. She underwent a CT scan, and her medical management, she had chemotherapy and immunotherapy that she was tried on, but unfortunately her symptoms persisted. She was evaluated to see if she was a surgical candidate, and she was not, because surgery is not found to be super helpful for multifocal malignant bowel obstruction. She did have some ascites, but it wasn't significant enough for her to have an intraperitoneal catheter placed. But when she had an NG tube placed, that her symptoms did improve. So then she was considered a candidate for more long-term venting gastrostomy tube. And just one note is that if the patient has an NG tube placed and there's no benefit to that and her symptoms don't improve, she would not be a candidate for a venting gastrostomy tube because it's unlikely that it's going to help. This is just a little checklist that I put together for pre-gastrostomy tube evaluation on a CT. The reason I did that is at Michigan, we actually use CT with oral contrast and without IV contrast as a medium prior to percutaneous gastrostomy tube placement, but I know that that's not necessarily the norm. But if you ever come across such a study, this is what you might consider. So is there a window for placement? Are the epigastric arteries in the way? Because that can be a source of bleeding. Any severe ascites, free air, abdominal wall infection at the site of placement, or are there any sort of organs in the way of where you would want to place your tube? And then marked peritoneal carcinomatosis, like our patient had, is typically considered something that people want to be aware of, and then gastric cancer or prior gastric surgery. So this is an interesting study that I had come across that described an infracolic approach to percutaneous gastrostomy tube, either gastrostomy or gastrojejunectomy tube placement. This approach actually uses this approach has the needle go through the greater omentum here, the transverse mesocolon gastrocolic ligament, and the lesser sac in order to get into the stomach. So I just thought that it was pretty interesting. Normally you would think, oh, there's not a good approach, but you can still access the stomach in this way, although it is a little bit riskier. And then also at Michigan, we do something pretty unique called a percutaneous transesophageal gastrostomy tube placement, a PTEG. And this technique is cool because you take a needle and you place it through the neck to puncture a balloon, which is positioned in the esophagus, to be able to get that cervical access into the esophagus, which then is subsequently fed into the stomach. And so this is that needle that's puncturing the balloon that's in the esophagus. And this is a little diagram of that. This is a sagittal CT, which is just going to show you the course of the tube. I went through that a little quickly, but here's that tube. So just if you track it, you'll be able to see that it's going into the esophagus and then down.
So it looks like they might even go through the thyroid gland sometimes.
I think that's ideally they avoid that because I don't think we would want to put that tube there. But yeah. So then these are both final fluoroscopic images of the tube, and it's just something that you should be aware of. I know it's not super common, but if you do end up seeing kind of like a random tube that's going from the neck down into the stomach, that's probably what this is. And then my second case.
Hold on one second.